So this section is about sending people home who we would normally put in the hospital, and giving you the data to help you make this transition. Because the most expensive decision that we make is not you ordered too many CAT scans, it's who you're admitting to the hospital, because that's an expensive deal as soon as you would put them in the hospital. And for us, in terms of our risk, we don't worry about the people we admit, we worry about the people who we send home. So when we have people who are traditionally admitted to the hospital, and we're getting data to send them home, that's going to be a little tougher to embrace. So here's the first paper here talks about a list of diagnoses where you can send them home if they meet certain criteria. Like we're talking about DVTs, well, that's kind of pretty straightforward. But pulmonary emboli going home, pneumonia going home, pneumothorax going home, chemotherapy-induced febrile neutropenia. That's kind of a scary one. A cancer patient comes in, they got basically no white cells to their name, they got a fever, and they can send some of those people home. The answer is yes. Now, a lot of times this decision is going to be made by you in conjunction with their oncologist or some other doctor who's going to follow them up, because all these people who are going to get home are going to need to have reasonably assured follow-up. So let's start going through this list. PEs first. How many of you have sent PE patients home? Do you do this with any regularity? It's pretty kind of uncommon that happens. Any of you work with Kaiser? Any Kaiser people here? Because Kaiser's been sending people home for 15 years, and they have probably the most large collective experience at it. And Kaiser's nice because all the patients who go into Kaiser ER, they got a backup doctor in terms of every specialty that's going to take care of them. And they also can narrow the variability between what doctors are doing, because they're going to say to the pulmonologist or the emergency physicians, okay, let's start narrowing variability. Let's look at starting with criteria. Let's agree on these criteria, and this is what we're going to do. In the community, it's much more difficult to get physicians to embrace that kind of idea. But in any case, a Dutch study, almost 300 people who had pulmonary emboli. That's a lot of people, pulmonary emboli. They had a list of criteria where if you meet these criteria, you could probably go home. And they're kind of like intuitive, like you're hemodynamically stable, you're not getting thrombolysis, you're not bleeding, you don't need oxygen to maintain your O2 sat in a reasonable neighborhood, you're not taking an anticoagulant and now on top of it have a PE, you're not in severe pain, you have good contacts in terms of getting you back here if you get into trouble, you got a telephone, you got a car, you got somebody to take care of you. And your kidneys are okay, and your liver's okay, and basically we meet all those, we think you can go home. 50% in this study of the 300 people met the criteria to go home. That's pretty much the number that you see pretty frequently in European studies. American studies were a little bit more conservative, but American studies, I'll show you, it's 25% of all the PEs can go home. So in this study, 50%. And how did they do? Well, all of these studies are old enough where they were using heparin and a vitamin K antagonist. So they started the heparin in the emergency department. They would teach people how to give shots at home, kind of thing, and start them on vitamin K. We don't have to deal with that now that we have the NOACs. But in any case, this is what's basically underlining all of these studies. And basically, there's no comparison in this study with inpatients. But I do have a study here that says patients who can go home, let them go home. Patients who can go home, put them in the hospital. And how do they do to compare them? And you'll see, obviously, that it's going to be pretty much the same. These people did really quite well in the major bleeding, 0.7%, because that's what we're concerned about, bleeding, or maybe their emboli is getting worse, and they're going to get more short of breath and more hemodynamically unstable, and that really didn't occur. So the question is how safe it is to send somebody home. So that's paper number 2, systematic review. This systematic review, 1,258 PE patients. This is a review that looked at big number. The rate of recurrent venous thromboembolism in patients who were treated as an outpatient, 1.5%. That number, 1.5% in terms of recurrences, generally it's in the neighborhood of 2, really doesn't have anything to do whether you're treated in the hospital or you're treated at home. Recurrences are related to not the fact that what building you're in when you're getting the medicine, but other factors that cause the PE in the first place. Then that's related with to recurrences, and that's really you're not treating that by giving them the treatment for this pulmonary embolism. Major bleeding, less than 1%. Fatal intracranial hemorrhages, 0.25%. Overall 3-month mortality, 1.6%. You have to remember, a lot of people who go home who have PEs have cancer. And so that's kind of like the most humane thing to do is say, listen, you can go home, we'll give you the same treatment. I know you want to be home. You're not going to get much more benefit by being in the hospital. When you think about it, what are they going to get being in the hospital? They're going to get bad food, a buzzer that is not connected to anything. Where's the nurse? Where's the nurse kind of thing. You'd all rather be at home, all things being equal. A little bit more on safety is paper number 4. This is from the Annals of Emergency Medicine back in 2012. It's a Kaiser paper where they looked at a bunch of other papers. They looked at 8 studies. 7 were observational. We looked at we're going to observe, we're not going to intervene. We're just going to see how things do on outpatients versus inpatients. 1 randomized controlled trial the whole thing involved 777 PE patients, all treated as outpatients. 3 of these studies used something that ranked people in terms of risk. We'll talk about that in a second. Others basically said, here's a list of criteria. If you meet all these criteria, you can go home. If you have one of them, you don't have one of them, you're in. The mortality rate at 90 days in 7 of the studies, or at 180 days in another study, was 2.8%. So the number is around 2%. The other study was 1.75. This is around 2%. Now, when you look at the deaths, there were 22 deaths. 2 of them, of the 22, were attributed to venous thromboembolism or hemorrhage. All of the rest were attributed to something else. So when you have a person who has a PE, who may have a chronic disease or like cancer, and you look at, well, why did they die? You can't necessarily ascribe it to PE because they did in this only 2. That meant the death rate due to pulmonary embolism in these people was 0.26%. When they said specifically that was the cause. Although it's always a little difficult to say specifically why somebody died. The highest complication rates are in those people who have pre-existing cancer, as you might intuit. What about the NOACs? The NOACs are kind of cool. We'll just give you this pill. This pill, in a couple of hours, will probably take out your 10A inhibitor, or take this out, or take that, whatever they're working on. And when the pill's gone, everything goes back to normal. Some of the pills last 12 hours. Some of the last, longer than that. Do we need to give heparin in those cases? I think that's kind of debatable. Do you have any experience where you give heparin and these pills? I mean, I'm not sure why you would. The pill does the job. So this is kind of like a little revolution. So now we can basically say, you've got this, you meet the criteria to go home. I expected you want to go home. We're going to start you on this pill right now, take this pill now, and we're going to continue on it. And your doctor's going to see you in a day or 2, and make sure that you have a phone, somebody always with you, and it's probably reasonable for a large number of people. The Kaiser system has felt real comfortable sending people home. Many of us don't, because first of all, we think pulmonary embolism is a relatively rare disease. When you go home at the end of the night and say, I saw a PE today. So we don't really have a lot of them in terms of our own experience to say, okay, I feel real comfortable sending this person home. So the idea here is get the emergency people to get together with the pulmonary people and the hematology and cancer people and say, okay, Are we going to start embracing this? The literature is supporting it, but we have to nudge it along kind of thing because people would rather be at home. They get in trouble in the hospital. So maybe we can develop our own criteria. And when you do that in a hospital setting, and everybody has buy-in and everybody has input, it won't be all they're driving us down our throat. No, this is our collective decision based on the literature that we looked at that said this is a reasonable thing to do. And that way, nobody's going to be an outlier and say, well, this guy's some kind of weirdo, basically sending everybody home. That won't be the case. It's like, this is what we do. Evidence-based, narrow variability, good follow-up. And that's, in the environment like Kaiser, they can do that much more easily. But in any case, Indiana University, number 5, small study, 106 patients. Mean age is 47. Is that your experience, PE patients at a mean age of 47? Well, this is in Indiana. Maybe that's what happened there. DVTs, 71 had DVTs, 30 had PEs, and 5 of them had both. I bet you more than 5 had both. There's a great study done a long time ago of people who had DVTs who were otherwise asymptomatic. And they did lung scans in all of them. 50% of them, of the lung scans were read high probability for pulmonary embolism. They had already embolized, and they just didn't know it, they didn't feel it, kind of thing. But the scan said half of them had already embolized. So the idea is when you have a DVT, you can say, oh, I'm glad we got you before you embolized. Fact is, they probably have already. It wasn't a big one, not a symptomatic one. In any case, in this study, they gave them enoxaparin and then rivaroxaban. The recurrence rate was 2%. It's always 2%, 2%, 2%. That's the recurrence rate. And the rate of bleeding, pretty limited. No patient developed a recurrence or a new episode of VTE on treatment, and there was no instance of clinically relevant bleeding while on treatment. Can't do much better than that. Risk stratification tools. So 5 is a study of 19 emergency departments. Big study, 19 emergency departments. Stable, low-risk patients as determined by the Pulmonary Embolism Severity Index. Pulmonary Embolism Severity Index. And I think there's a little chart in your manual there. So where do you find the Pulmonary Embolism Severity Index? You go to MD Calc. You know that study, that site, MD Calc? You go to MD Calc. It's got, here's the checklist. You've put it into the yes, no, yes, no, yes, no, no. It totals it up for you. It basically says low, medium, high. There's like 5 classifications of risk. And the nice thing about having something like that is it's not just using your judgment. Because your judgment may be pretty good, but on average, I would rather rely, if I'm going to be doing something that is not standard, we're going to start sending patients home who meet low-risk criteria. I would rather rely on, I followed the guidelines to the best of my ability, I followed the guidelines, and I just didn't say, well, I think you can go home, because it's probably not a great idea. So go to MD Calc. It'll tell you the risk scores. There's 11 items. They made a modified one. It has only 7 items for you to fill in. Tells you the risk, low risk, they can go home. In this study, everybody who's treated with enoxaparin, they got it shots at home and vitamin K antagonists. Then there was the people who just got the outpatient treatment. And recurrence of VTE within 90 days, 1%. The outpatient group, the recurrence rate was about the same. Major bleeding, 1.8 versus 0.7. So it's not happening a lot. It's really pretty infrequent. At 14 days, 92% of the outpatients and 95% of the inpatients were satisfied with their care. I don't understand that. Why would anybody want to be in the hospital? They were in the hospital for about 4 days. Then they went out on their outpatient treatment. So the only question is, and the other people were in the hospital for half a day while they initiated this treatment. So I'm kind of surprised at that. But the idea is they're not going to be in here for a long, long time. I mean, if you're going to treat somebody in the hospital for a PE for 4 days, well, actually, they're going to be treated longer than that when they go home. This doesn't stop at the end of 4 days. And so it's kind of, what are we buying for that 4-day period? And the fact of the matter is in that low-risk patients, which are easily ascertained, you're not buying very much. So 8, we don't need to go into that. That's where they basically said, let's refine this pulmonary severity index, and we're going to get it down to fewer points. There's a little chart there. And so this is a collaborative endeavor. You go back and say, come on, let's look at treating these PE patients that are low risk, at sending them home. Here's the data. And I tell you, if you did a search on the web, you'll find lots and lots and lots and lots of papers about this, about sending people home. Lots of them from Kaiser. So I think that this is something where I don't really feel comfortable about it, because this is what I've done all my life. We've admitted patients. Well, if you just do that all your life, you'll never get a patient to go home who really wants to go home and will get no benefit out of the hospital. So we need some courageous people here. Community-acquired pneumonia. Now, that's another one. Pneumonia I'm done. I'm not worrying. I'm not going to lose any sleep. But the fact of the matter is that maybe they'll get just as well if they're home. Their families around them. That's where they want to be. And we have all the risks of getting MRSA and all things that you can get into the hospital. I'm going to give you 2 papers that were not in your manual to try to put into perspective how important it is that we start sending people home and the variability. So the first paper is about adults, 2,000 adults, 2,069 adult patients. This was published in the Annals of Emergency Medicine in January of 2012. 2,000 patients treated at LDS Hospital in Salt Lake City by 18 board-certified emergency physicians. And they looked at what was the disposition of these 2,000 people by doctor. One doctor admitted 38% of his or her pneumonia patients. Another doctor admitted 79% of his or her pneumonia patients. Well, was this doctor's patient sicker? Well, of course not. Of course not. We're talking about 2,000 cases. Variability in admission, 38 to 78, double. Variability was not explained by illness severity. Not explained, well, why? That would be the thing that would do it. It was not explained by illness severity, time of day of the week, resident care in conjunction with the attending physician, or patient or physician demographics. Old doctors, young doctors, didn't matter. Twice, 38, 78, same patients. There was a PED study. This was published in the Journal called Pediatrics in August of 2013. They looked at 100,000 children seen in 35 pediatric emergency departments. So the pediatric emergency departments, these are the pros. These are the people who know how to treat children. They have taken all the extra study. They know what they're doing. Or do they? 100,000 cases. And they looked at 36 hospitals, and they looked at how many studies, how many tests were done in association with a pneumonia patient, and how many of those patients then got admitted. And it turned out that the hospitals that did the most tests admitted the most patients. The hospitals that did the most tests, the top third, they did the most tests, they admitted 76% of their patients. The hospitals in the lowest third of test utilization, it admitted 18%. 18%, 38%. That's twice. This like the other study was twice. This is by hospital. 18% for this hospital, 36% for that hospital admitted pneumonia patients. These guys did a lot of tests. These guys did not do a lot of tests. And we're talking about 100,000 cases. So what's the variable number there? It's the variable is this hospital, this is the way we do it. We've always done it this way. This is the way we feel comfortable. So it's the internal behavior of a group at that hospital versus the internal behavior of a group at that hospital. Twice as many people are going to get admitted under that situation. And when you look at severity, No difference, no difference. You think that one hospital gets all the sick cases and one hospital gets all the not-so-sick pneumonias? No, it wasn't that at all. So these are some of the reasons. In this study where they looked at hospital behavior, 18% versus 36%, I would have loved to have seen what the individual doctor behavior was, because they've just amassed them here. 1/3 of the hospitals, top third, lower third kind of thing. I bet you individual doctor performance was all over the dartboard. Yes, sir. Mayo Clinic. It's a little schlocky place there. You know. Every one of these requires follow-up.
And that's what I'm saying. Don't give follow-up.
Well, that's in some places. I mean, I worked in Los Angeles for 25 years, and we could get follow-up where I was. And Kaiser, they get follow-up. Mayo Clinic, you get follow-up.
Exactly. It works fine in a system that's committed.
Right.
And actually, you have to get the insurance.
You can't do this in a vacuum. You have to have your primary care doctors on board. You have to have a kind of a consensus. We're going to follow the Pneumonia Severity Index criteria, and we're going to try to move into the 20th century in terms of moving this. Because you could look at what is the baseline at your hospital. How many patients who go home who have the diagnosis, ICD-9 pneumonia, how many of them go home? It's probably very, very few. So this is an idea to try to push, because what would you like? You wouldn't want to be in the hospital if you could avoid it. I was at one of these conferences, and my wife had the audacity to go to our emergency department because she was coughing a little bit, wimping it out. And sure enough, she had this big pneumonia, a big Goomba there. You know, here's the Z-Pack, get out of there. You know, she went back, she left the hospital. And when I looked at her x-ray, this is not the x-ray of a viral pneumonia. This is like something a little bit more serious than that. So I'm sure you send patients home. I just think that basically the literature says that we can send more home. The Pneumonia Severity Index, we're kind of running short on time here. I have another version of this that we'll pick it up on the second half hour of this. But I did want to make one point. The Pneumonia Severity Index, the study that generated it was pretty astronomical. It's like, where's my data on it? You know, when you make a guideline, you test your guideline. You derive it. You derive the guideline, and then you test the guideline. The derivation, the number of patients involved in the derivation of the pneumonia severity score was 14,199. This study was published in 1997. 14,000 people were used to derive the guidelines. How many people were used to test the guidelines that were derived by the 14,000? 38,000 pneumonia patients. Can you imagine the time and money and effort? We're talking about 52,000 pneumonia patients. The job was to come up with a guideline that we can depend on. So this, by definition, became the gold standard in terms of pneumonia. Now, there have been others, but I just wanted to give you, I've never seen 52,000 people involved in the development and validation of a set of guidelines kind of thing. But we'll talk about that a little bit more in phase 2.